Thank you, Dr. Ashwag. I would like to thank the organizing and scientific committee for inviting me in this conference. My talk will be about using anticoagulant in antiphospholipid syndrome patients. This is a topic of controversy, so we will see what we found in the literature. I have nothing to disclose. This is the outline of my presentation. As introduction, the antiphospholipid syndrome is a disease that presents, it's an acquired disease with systemic autoimmune disorder that presents with arterial and venous thrombosis. And also it is associated with pregnancy morbidity in adults with persistence of antiphospholipid antibody in the patient's serum. It's also pediatric, usually it will present below age of 18 years. What is the difference between pediatric and adult antiphospholipid syndrome? Usually in pediatric, the challenges we face that those patients, they present with non-thrombotic events. They have more non-thrombotic than thrombotic events. They present with hematological, neurological, sometimes with dermatological manifestation. And also, the good thing about pediatric patients, they have less risk factor or prothrombotic risk factor comparing with adult patients. But the problem with diagnosing patients with antiphospholipid syndrome in pediatric, we don't have a specific criteria to diagnose those patients with antiphospholipid syndrome. So there was criteria, Sabron criteria, which were used many years back and revised in 2006, and they come up with this criteria that consists of clinical and laboratory criteria. The clinical including vascular events or thrombosis in addition to pregnancy morbidity, and also the laboratory testing. And the patient need to have at least one clinical and one laboratory test positivity of autoantibody of antiphospholipid antibody to label him as antiphospholipid syndrome. But this is not specific for pediatrics. So the pediatric registry and breast conference in 2004, they gathered and they thought that we have to make a criteria that is specific for pediatric and more applicable for our age group. So they came up with this preliminary classification. Again, it's a clinical and laboratory classification, but they remove the part related to pregnancy and fetal loss. After that, the SHARE initiative, they made a classification or recommendation for diagnosis and treatment of patients with antiphospholipid antibody positivity, because they thought that the pediatric registry publication was not enough because they studied only 120 patients and it doesn't reflect their reality. So they came up with this European evidence-based recommendation for diagnosis and for treatment for pediatric age group patients. Their aim was to have the better practice in diagnosing treatment of patients with antiphospholipid, and also they discuss a group that were not discussed in adult age group, which is the children who were born with mothers with antiphospholipid antibody, with antiphospholipid syndrome. If you can note, this is their recommendation for diagnosis and treatment, and the highest evidence, of course, were found that patient should have positivity of antiphospholipid antibody, either one or the three antiphospholipid antibodies. So to diagnose a patient and to treat them, we need to know what is their clinical manifestation. Commonly, those patients will present with, as I mentioned, thrombotic or non-thrombotic events, and sometimes the patient will have positive antiphospholipid antibodies, and he is or she is asymptomatic. And of course, we have the severe form of antiphospholipid syndrome, which is catastrophic antiphospholipid syndrome. The thrombotic in pediatric, they have more of venous thrombosis comparing with adult and comparing with arterial thrombosis. because I think related to the underlying causes of presentation of patient with antiphospholipid syndrome. The non-thrombotic events, we see it in the patient of pediatric age group. They come with hematological, sometimes neurological, like seizures, choreas, or other manifestation, in addition to dermatological, like livedo reticularis, Raynaud's phenomena. So all of these are non-thrombotic manifestation, and we see it commonly with patients of pediatric age group. The diagnosis, of course, we have to have the antibody positivity. The positivity of antibody, we know that in some situations, especially in pediatric, we have infection that can give a positive, wrong positive test for antiphospholipid antibody positivity in the serum. So we have to have it at least 2 times with 12-week duration. And they found that the patient who had anticardiolipin and lupus anticoagulant, they have more specificity and sensitivity for antiphospholipid syndrome. So what is the recommendation if we diagnose a patient with antiphospholipid syndrome? I categorize it according to the type or the association of this disease. But still, the literature about antiphospholipid syndrome treatment is still in pediatric. It's not rich about those information or this treatment. And our aim in treating patients with antiphospholipid syndrome is to prevent thrombosis or rethrombosis. So the secondary prophylaxis is very important in those patients. But the main thing we have to do to prevent or to overcome the risk factor, if the patient have any one of these risk factors, we have to deal with that before he develop a thrombosis. The primary antiphospholipid syndrome, we don't see it a lot in pediatric and doesn't have a definitive definition. But if we have a patient with a thrombosis and positive antiphospholipid antibodies, this is a primary antiphospholipid syndrome if there is no underlying cause. And it has this characteristic feature for this type of disease. Usually it will come in younger age, and it's involved arterial thrombosis rather than venous thrombosis if we compare it with other type of antiphospholipid syndrome. The most common type is the one associated with other autoimmune diseases, and commonly SLE. We know that pediatric with childhood lupus, they have higher risk to develop association with antiphospholipid syndrome. So we need to screen all our patients who are diagnosed with childhood lupus for antiphospholipid syndrome or antiphospholipid antibodies. Even in adults, we have in pediatric higher rate of association with antiphospholipid antibodies. This is a study that shows that the association of antiphospholipid antibodies with the children with SLE. The first one in the left was done by Prof. Al-Mayouf in King Faisal Hospital, and they studied the patient with lupus nephritis and the significance of association of antiphospholipid antibodies. There was no much difference between the two groups. However, they found that the small number of patients who had antiphospholipid antibody positivity, they have more refractory disease and they end up with end-stage renal disease. The other study, they saw that the patient who had SLE and they have positivity of antiphospholipid antibodies, they have more of tissue damage and severe disease. So if we have a patient who is diagnosed with SLE or other autoimmune disease and he had positivity of antiphospholipid antibody, we need to give them an prophylaxis treatment with low dose of aspirin, of course, in addition to other treatment like hydroxychloroquine. We know that hydroxychloroquine have a preventive effect on the patient who had antiphospholipid positivity with SLE. However, the recommendation to add low dose of aspirin for patient with SLE, especially if the patient has triple antibody positivity, meaning that the patient has positive anti-beta-2 glycoprotein, anticardiolipin, and lupus anticoagulant. Especially for lupus anticoagulant, they found that the patient who had positive lupus anticoagulant, they have higher risk for thrombosis. In this study, they saw that in 5 international cohort study, they studied the efficacy of aspirin in preventing an event in patients with SLE, and they found that there is significant decline in the risk to develop thrombosis in those patients. So aspirin can be added to the patient who had positive antiphospholipid antibodies with SLE. What if the thrombosis happen? We are treating the patient as same as any acute event of thrombosis with anticoagulant, either low molecular weight heparin or unfractionated heparin, especially, and of course, with the consultation with hematologist. In pediatric, it's preferable to start them with low molecular weight heparin. If those patients persist to have the antibodies, so they need the long-term prophylaxis or treatment with anticoagulation. If we have a venous thrombosis, we treat them with low molecular weight heparin, and it will be followed by vitamin K antagonist, aiming like warfarin, aiming for INR between 2 to 3. If the patient has arterial events, so we add, with the anticoagulant, we add aspirin or anti-aggregation treatment, and it has better effect to prevent the complication of this event. What if the patient develop a recurrence of the thrombosis while he is on treatment with vitamin D antagonist warfarin? So we aim for higher INR, 3 to 4, or we extend the dose, or we use alternative treatment by extending the dose of low molecular weight heparin. The EULAR recommendation, of course, it was for adult, but they recommend to add low molecular weight heparin to the vitamin K antagonist instead of increasing the targeted INR, so it's better outcome and to prevent the complication of bleeding. The other medication that has been used for patients with antiphospholipid syndrome is the oral anticoagulant treatment. This medication is targeting the pathway of coagulation, mainly factor X and thrombin. This medication has an advantage comparing with other because it can be given orally and has no laboratory monitoring tests and has short half-life. Can be considered also for the patient who had vitamin K antagonist contraindication. But this medication cannot be used as a first line of treatment, and it cannot be used if the patient has 3 or triple antibody positivity. And we have it common in our patient today. Commonly, they will have at least 2 antibody positive if they have especially that come with SLE. Also, this medication should be avoided with the patient who has arterial thrombosis or who had cardiac disease or valvular disease secondary to antiphospholipid antibody syndrome. It was studied in pediatric in many occasions in comparison with they studied the efficacy and safety of this treatment, and it was safe, but there is no superiority with this medication with warfarin, which is most of the people are more familiar with this medication comparing with the oral anticoagulant. Another type of oral anticoagulant was used in adult, and unfortunately they found that those medications they increase the risk for thrombosis in adult population comparing with warfarin. The other type of, or other entity of this disease is the children who were born to mothers with positive antiphospholipid antibodies. Thrombosis can happen with those children, however, with those babies. However, it's very rare to see thrombosis for infants with mother of antiphospholipid syndrome. We will find the same antibody in the infant that was found in the mother, but it should be cleared by 6 months up to 2 years. And the outcome for those patients is very limited in the literature. There is a case reports about thrombosis, but most of the time it will be associated with infection or other precipitating factor. That's why they develop thrombosis rather than a presentation only of the antibodies of antiphospholipid antibodies themselves. But they found that those babies who were born from mothers with antiphospholipid antibodies, they have higher risk to develop neurodevelopmental abnormalities. So those patients need a long-term follow-up, even if the antibodies were cleared from their serum. In this large European registry, they studied 134 babies for mothers who were having antiphospholipid antibody positivity, and they found that those patients, they don't have thrombosis, they don't have autoimmune disease like SLE, but they have a neurodevelopmental abnormality, and there is no clear explanation for this neurodevelopmental abnormality. However, they recommend to have a long follow-up for those patients with careful neurological assessment during their growth. And also they found that this babies may develop autism later on if their mother were affected with antiphospholipid syndrome. There is no rule to give anticoagulant treatment for babies if we found that they have antiphospholipid antibody positivity. We should wait to clearance of those antibodies unless the patient develop severe disease, he developed thrombosis, so we will deal with him like an acute event of thrombosis and we treat them accordingly. The next entity is the catastrophic antiphospholipid syndrome. We know this is a very severe and life-threatening condition. It's characterized by microthrombotic, multithrombotic microangiopathic disease with cytokines storm. This is very rapid, very severe disease. And usually it will be in pediatric age group, commonly it will be precipitated by infection. So we always, we have to keep infection in our mind if we have a patient with autoimmune disease and he developed catastrophic antiphospholipid syndrome. The treatment of this disease in all literature and recommendation, including CAPS task force and SHARE initiative, they recommend to start combined treatment for those patients with a steroid and anticoagulation treatment, either warfarin, either low-molecular-weight heparin or unfractionated heparin, in addition to plasmapheresis plus minus IVIG. So those patients will have a better outcome and better prognosis if we start them with combination treatment with those medication.
2 minutes left, Dr. Ashwa. 2 minutes.
The use of biologic treatment are still under studies for the patient who had catastrophic antiphospholipid syndrome. However, the SHARE initiative, they recommend if the patient has catastrophic antiphospholipid syndrome and they did not have a response with a combination treatment, rituximab can be considered with those patients. The other medication like eculizumab and complement inhibitor is still under studies for pediatric age group. In adult, they are using it, but in pediatric still it's under study. And there is no clear, strong evidence about the beneficial of this medication. I would like to talk about one of the events that may happen or syndrome that may happen with the patient who had antiphospholipid syndrome, which is lupus anticoagulant hypoproteinemia syndrome. This may happen with the patient who had secondary antiphospholipid syndrome or associated with other disease, mainly lupus. Those patients will present with a bleeding symptom. And in the laboratory, we will find them having prolonged BT and BTT. The patient will present with skin bleeding and epistaxis, secondary to clearance of prothrombin, antiprothrombin antibody complex from the circulation. Those patients, they require to be treated with immunosuppressive treatment like corticosteroid, cyclophosphamide, and sometimes rituximab. Still, the evidence is coming from adult literature rather than pediatric. So what about the non-criteria or non-thrombotic manifestation for antiphospholipid syndrome patients? There is no standard evidence for treating those patients, so each patient will be treated accordingly. So there is a successful case report that the patient presenting with chorea secondary to positivity of antiphospholipid syndrome, he was treated with hydroxychloroquine, MMF, and IVIG. If we have skin manifestation like livid reticularis, there is no treatment required, but if the patient has a skin ulceration, antiplatelet can be used, meaning aspirin. If the patient has heart involvement and valvular disease, even if we treat them with anticoagulation, it won't prevent the progression of the disease and the severity of involvement of the valve. Eventually, those patients will end up having valvular replacement because of the severity of cardiac involvement. So, as primary prophylaxis for antiphospholipid syndrome, if we have a SLE patient with positivity of antibody, we will give platelet, otherwise antiplatelet. Otherwise, there is no strong evidence of giving all the patients who had antiphospholipid antibody syndrome positivity as a primary prophylaxis, especially if the patient is symptomatic. If the patient is symptomatic, he didn't need to be exposed to this medication unless he will go under surgery or long-term immobilization. Low molecular weight heparin can be given for the patient who had positive antibody but asymptomatic.
1 minute, Dr. Ashwa.
Okay. This is the last meeting was done for the task force. It was done 2019, and they came up with a long list of medication, new trends in treating antiphospholipid syndrome, but this is all on adult information. Is it applicable for pediatric? Still, we don't know. We need further study to see and randomized control trials to give us an idea, is this useful in pediatric or not? Thank you.
يعطيك العافية دكتورة. Thank you. We have time for one question only. A burning question.
يعطيك العافية دكتور أشرف. It's very informative and well prepared presentation. I have two things to ask. First, one is regarding the possibility of having negative seroconversion of the autoantibodies for antiphospholipid antibodies with the time, with using of immunosuppressive medication. This is first. Second is regarding the non-criterial antiphospholipid antibodies. Specifically now they are talking about antiprothrombin antibodies, and these patients probably could be more risk and need closer follow-up. Thank you.
Yeah, for the positivity of antibody, that's why in the literature they mention if the patient has persistent antibody, they need a long-term treatment with anticoagulation, warfarin, or vitamin K antagonist. So it can convert to negative, yes. The next question, Doctor? Can you repeat the question? I didn't. Okay. Actually, they found that the lupus anticoagulant antibodies is the highest antibody that can risk patients for thrombosis. I didn't find a specific study talking about antithrombin antibody for antiphospholipid syndrome.